In the first trimester, maternal blood glucose is lower compared to non-pregnant women. However, during the second and third trimester, there is a steady increase in hormones such as estrogen, progesterone, HPL or human placental lactogen, which causes insulin resistance. A normal response to increased insulin resistance is increased insulin secretion. This means pregnant women with type 1 and type 2 diabetes are taking insulin will typically need less insulin in the first trimester compared to the second and third trimester. Whereas women with gestational diabetes who are not able to keep blood glucose in an optimal range with nutrition and activity recommendations will typically need to start on insulin due to increased insulin resistance and the placental hormones in the second and third trimester. External factors such as excessive stress or an unhealthy living or work environment can negatively affect blood glucose levels, making them higher, while other factors like food, beverages, and even herbs can increase or decrease blood glucose when taken internally. For example, a diet consistent of low glycemic carbohydrates have been shown in clinical practice and in research to be beneficial for women seeking to improve blood glucose control. Add in appropriate amount of protein and fat with these low glycemic carbs are helpful as well. Timing of the meal and quality of the meal is crucial when trying to maintain optimal blood glucose levels. The right macronutrient composition, so the protein, the fat, in addition to the carbohydrates, are key in maintaining blood glucose in that range. Look at the whole person and inquire about the factors that affect blood glucose, such as stress, sleep, activity, and not just food and beverage, which is important when considering time in range and blood glucose fluctuations. A very tight or narrow blood glucose range during pregnancy, such as 60 to 90s fasting and lower 100s postprandial, is typically recommended to achieve glycemic control in order to decrease maternal complications, such as diabetic retinopathy, diabetic nephropathy, diabetic ketoacidosis, hypertension, difficulty delivering, and things of that sort. And when it comes to neonatal complications, these could be congenital malformations, neonatal hypoglycemia, macrosoma, and so on. So these are the reasons why we want to keep blood sugars in that very narrow range. Yes and no. In clinical practice, time and range targets for pregnancy is individualized. However, a typical range is set to 70 to 130 compared to the norm of 70 to 180. Continuous glucose monitor, or CGM, time and range research, specifically in pregnancy, is not set in stone and is therefore evolving. Currently, data is available to support the use of CGM time and range for pregnant women with type 1 diabetes to assess glycemic control. For example, in the concept randomized control trial, more time spent in time and range, along with other factors, resulted in lower neonatal adverse effects. However, more research is needed when assessing women with type 2 diabetes and gestational diabetes. Going forward, time in range and mean blood glucose are important metrics practitioners should be aware of and may soon, though, replace A1C due to their ability to properly estimate glycemic control in pregnancy. So A1C, though, still remains important in assessing glycemic control, especially in the preconception stages. But during pregnancy, A1C may not be as reliable since the rapid red blood cell turnover rate may not provide the best information on glucose management when used alone. For more information, visit the American Diabetes Association Time in Range website at professional.diabetes.org/time in range.